Hello, everyone. Welcome to this academic talk by the AO Spine Youth Club. Today, we are exploring the work of the AO Spine Knowledge Forum Tumors. My name is Angelica Arce. I am from Mexico and I'm currently doing my residency in orthopedic surgery in Serbia. And joining me are my colleagues.
Hi, I'm Dr. Taarini Johri. I'm from India and I'm a spine surgeon, orthopedic.
Hello, I am Dr. Mădălina Ancuța, a neurosurgery resident in my fifth year now, from Romania, currently in France.
We are truly honored to have with us today Dr. Charles Fisher. He is a professor and former head of the Combined Neurosurgical and Orthopedic Spine Program at the Vancouver General Hospital and the University of British Columbia in Canada. He's a world renowned for his expertise in spine oncology and complex spine surgery. Dr. Fisher is the former chairman of the AO Knowledge Forum Tumors and a 2019 Leon Wills Award recipient. With nearly 350 publications, he is a name that us as fellows and residents come across frequently when studying. Dr. Fisher, thank you very much for joining us today.
Yeah, thank you for inviting me. It's great.
So let's begin. Dr. Fisher, this question is going to be about recent advances. So spine surgery has evolved very rapidly in the past few years. There's robotics, navigation, AI and machine learning, and much more. So according to you, which recent advancement is the most promising when it comes to the future of spine oncosurgery?
Well, that's a loaded question, and I think probably I'd look at it from a metastatic perspective and then a primary tumor perspective. And I think on the metastatic side, AI will really dramatically improve our decision making on when to operate on patients and when not to, not only based on their tumor or histology, but based, on their performance status, frailty, and probably a number of laboratory and imaging parameters as well. So I think AI in that world will be quite dramatic. On the primary tumor side, it's a little different. I think the world of omics and tissue banking and all the molecular analysis is going to really help things. Now, AI will drive that a bit. Quantum computing may drive that. There's a number of factors, but I guess the big thing for me is knowing how to approach a primary tumor. Do we need to do a big en-bloc resection and aggressive surgical resection or not? There's probably some histologies where you do and some where you don't, and some where adjuvant therapies will play a bigger role. So the robotics piece in oncology, I don't know if it's like, I think robotics is great, but I don't know if it's really going to play a role in oncology too much. I think it's more in the omics, AI, that arena.
There's some research, like a lot of people are studying AI and machine learning for classification systems. So is that also what you're pointing towards?
Yeah, exactly. Decision making, which is one of the most difficult things we face in oncology, right? The type of when to operate, the type of operation, the different therapies available pre or post-op. Yeah, so that's, I think, the real area that we're going to benefit from.
Thank you.
Yeah.
Good. That was perfect. Thank you for this great perspective on the future technology. Building on that point.
Was it perfect? I'm not that good.
Yes,
It wasn't perfect.
Yes, of course it was. Of course it was. Come on, Dr. Fisher.
Okay.
It was perfect. Building actually on that point, Dr. Fisher, while technology is making almost any resection technically possible, you've always championed the idea that biology is king. So my question is, how do we ensure the new generation doesn't become just master technicians at the expense of oncological wisdom?
Yeah, good question. I'm
Yes.
not sure if I'm not sure. It's not a perfect question. It's a good one. No, no, it's good. I'm not sure your generation's probably got a better perspective than my generation and the generation in between, in the sense of, I think biology is probably a lot more of your training now. I mean, when you're in training or early in your career, you're very surgically motivated and driven. But I think the curriculum now stresses biology and stresses the omic piece. So hopefully, you'll have a little more biological perspective than I might have had when I came out. With people early in their career, they lack the experience and judgment. Um, and that's where I think, AI will help. Some people talk about the end of the bed test, just standing there and looking at a patient with metastatic disease and knowing whether you should operate or not. I don't think you're going to have to do that too much. I think, as I mentioned in the previous question, you're going to have some better decision making thanks to classifications, thanks to AI, helping you make the decision and helping you with the biology. So you'll be armed with the surgical, skill, but I think you'll be better prepared biologically than we were for sure.
Okay.
Yes.
Thank you very much for your answer. It was very good.
Nearly perfect.
Yeah. Yeah, I'm thinking back. I didn't think it was good. It may be average. Anyway. Okay.
I just wanted to ask you now, in the management of adjuvant sensitive tumors, how has the role of radical surgery evolved? Do you feel that better systemic control has successfully reduced the surgical morbidity for these patients, or does an aggressive and block resection keep being the oncological gold standard despite better medical therapies?
Yeah, I think we haven't made as many advances as we might have. So there's, when you look at the histology of primary tumors and you look at the medically sensitive ones, osteogenic sarcoma, Ewing's would be the two that kind of jump out. It's certainly reduced the morbidity of those procedures, because neoadjuvant treatment in that group does shrink the tumor, and it can make your margins less aggressive. So I think it's very valuable there, and they're continuing to make advancements in chordoma and chondrosarcoma. We're still struggling with the drug world. Where we are making some improvements is in the radiation world, and certainly SBRT, or stereotactic radiation, has made a big difference there, to the point where some people, experts, are advocating radiation up front or radiation after, and some even that think that you'll get good local control with just radiation treatment alone. So that's probably reducing the surgical footprint a bit, as well as the medical world. But we're still got a number of histologies where we don't have the medical treatment that we'd like to have. And that sort of comes back to my first perfect answer, in the sense of where if we can look at the omics, the tissue of a particular tumor, and it can tell us the aggressiveness and help direct surgery, the ones that really need an en bloc resection with good margins, whereas another one that may not need that and respond well to radiation or neoadjuvant. That to me, I think, is going to be something that will really help us down the road to reduce the morbidity of the surgery. And the other thing is you got to be able to sort of say no, right? When is too big an operation, and it comes back to your guys' question before about technical skill without kind of good judgment, like creating too much morbidity from the operation. And I've been guilty of that over my career, where you think you're going to do it, but it's just too much of an insult on a patient. So you have to keep all those things in mind, but hopefully more drugs will come along and reduce that aggressiveness.
Dr. Fisher, could you tell us a bit more about omics? Like how often, how does it work?
Well, it started out as genomics, and now there's proteomics and looks at DNA and RNA. And I don't know, probably what I should know about it, but I think now most tumors, where the big breakthroughs in that. Melanoma was one with the BRAF mutation. So those patients had, they weren't necessarily going to be cured, but they had a dramatic response to certain targeted therapies that enabled them to live longer. So you'd be much more aggressive treating those patients, even though they had metastatic disease, and you wouldn't. So that was one. The lung cancers were another big one. EGFR positive lung cancer patients did much better. So that world is going to continue to evolve. Where it hasn't really occurred yet is in the primary tumor spine world. Now, maybe it has, and I'm not aware of it, but it's certainly going on with tissue banking and things. The problem with primary tumors, they're so rare. So they're, an orphan disease, right? So you need big registries to capture this data and be able to start to make some, I guess, if you get enough of them, then you can make some associations or some recommendations, but they're hard to gather, right? How many chordomas and the different regions and the different sizes, different variables. So it's going to take a while. Yeah. But does that answer your question about the omics? It's just, a matter of helping you decide by a particular biology of the tumor.
More like personalizing the treatment to the biology of the tumor based on genetic studies.
Yeah.
All right.
Yeah. I remember I had this lady with bowel cancer and metastatic disease, and I operated on her for metastatic disease, and I said to the medical oncologist, "Do you want me to send the tissue?" And they go, "Oh, well, that would be a good idea." And she's still alive like 10 years later because her histology matched perfectly with this, was a blood pressure medication. And it was an interesting, rare, but interesting result. Yeah.
That's very interesting.
Yeah.
Now, if we can turn a little bit this interview into a discussion. As a driving force behind the knowledge forums, you've spent decades turning clinical intuition into objective data. However, what is the most uncomfortable truth that the data has taught you, something that perhaps went against everything you were taught as a young fellow?
Well, do I have to talk about oncology?
Yeah, but in a personal kind of
yeah. I think that I'll say one thing generally in spine. When I was training, you had to fuse everything, and now we certainly know you don't. I mean, you didn't have to fuse discs, but certainly when we're looking at the decompression world now, we're we're not fusing as much. And I think that's a good thing. Now, if you look at oncology, I was taught about en bloc resection and margins and tumor because of my orthopedic training background. And I don't think that was as much part of the neurosurgical training background. But you had, pioneers like Zia Gokaslan and Larry Rines, who were neurosurgeons that led that world. So there was always a bit of a wrestling match with, how to treat these primary tumors. I'd see tumors, rush to the operating room that were primary tumors and decompressed. And, was taught that was the right thing to do because of neurological compromise. But clearly, if you take a primary tumor, and you don't know what it is, and you rush it to the operating room, and you can render that patient incurable by doing, an interlesional resection of that. So I think those truths, because of different disciplines and different attitudes, it kind of inspired me a little bit to take this on. And then the other area, to answer your question, is radiation. I was always sort of negative on radiation because of all not that surgery doesn't have its adverse event profile, but radiation, conventional radiotherapy, just didn't seem to have a tremendous benefit in most tumors, yet it was given, and there was lots of collateral damage with the radiation around the tumor. So now that's far different with targeted radiotherapy and SBRT. So I think that's changed a lot for me as well.
Okay, thank you.
You. So this one's also a discussion that we have specifically given time to because it was a very high in demand question by a lot of AO Spine Youth Club members. So we joined the AO Spine very early on in our careers, now as early as medical students. And through the Global Spine Congress and the regional conferences, as well as through the AO Spine Youth Club, we get the opportunity to closely learn and watch leaders such as you who contribute very meaningfully to spine. So we would love for you to share your journey from residency to becoming the chair of the AO Knowledge Forum Tumor, especially some guidance for someone who aspires to climb a similar career ladder.
Well, do you have 3 or 4 hours? Or are you?
A few.
No, I think it sort of happens organically, right? I don't think I was in residency thinking about a major academic career. Now, some people do. I didn't. So I think it kind of evolves based on people you meet and opportunities and, where you practice and things. For me, the most important step was my chairman wanted me to get a degree, a graduate degree. So I did a public health, and so I learned about clinical trials, and that gave me expertise. It gave me confidence in research and things, and it made me quite unique. It isn't anymore. It's almost part of a residency now, but that allowed me to have that area of expertise, and that just triggered me to kind of get more into the research piece. So I think getting a degree is a good idea, whether it's healthcare economics, whatever it might be. But should be something you like. And then after that, if you want to get into academics, you do need to publish. It's really our only current academic currency. I think there should be other ones, but that certainly is the most important one because it's objective. And that's not easy, but getting a couple of publications under your belt is important, and having a mentor, to help you with that. But it's hard to sit down and write a paper. I don't know if you guys have, but it's not easy. It shouldn't be hard. They're all the same. It's not like you're writing a novel, that has to be completely different. You need a good rationale for doing the study. You need a good question. And then once you have those two things, the methodology sort of takes care of itself. So I think that's a really important principle. Like, study something that in clinic every day you go, geez, I wish I knew the answer to that. And then next is you need to be collaborative, because most research, you want to do with a couple centers if you need data, if you need numbers. And when you're collaborative, like the four of you guys at the beginning of the talk having fun, like, that's good, right? You want to do that. You want to be talking about your experiences and questions you're asking, and solving those things together. So I do think you need to go to meetings and meet people, or you have groups like yours that you develop these peer relationships, and you have a common interest, and you set out to do it. And I think that's what enabled me early on with the Medtronic study groups before the knowledge forums, that I met all these clinical leaders, and I had my area of expertise, and I was able to help them, and they kind of inspired me. But you do have to get out to meetings, and you do have to meet people. I think that's a really important thing. And, once you do that, I think it's just your interest and drive and passion after that. But those are the essential ingredients, I think, to have an academic career. Not sure how clear that was, but did it make sense? It's a discussion. Tell me if something there didn't make sense.
From that, I got publish or perish. Have a good team that kind of drives you to solve questions and attend more meetings, so that you can constantly have that kind of curiosity, maybe, and find out good questions in your own clinics and wards, maybe.
Yeah, no, that's good. I wouldn't say publish or perish. I just think early on, it's all you've got. I wouldn't just be publishing for the sake of publishing. Publishing, sometimes you have to do some studies because they're part of a story. Because in getting grants, it's nice to have a story. So sometimes you have to do things that aren't necessarily that clinically relevant. But the big picture, you want to do things that are relevant. Yeah. But yeah, that's good. You got it all.
Thank you very much.
I'll look forward to seeing you in as your chairperson of a knowledge forum.
Hopefully soon.
Doctor, now I would like to ask you now, for residents and fellow, could you please walk us through the mental framework or stepwise clinical approach, let's say, from the first imaging and staging to biopsy and then definitive treatment, so we avoid rushing right into surgery before completely understanding the biology of the lesion that we have in front of us?
Yeah, that's a really good question, and one that I think is truly important. So where it really comes into being is the patient who presents with neurology, right, to the emergency department, and they're myelopathic, or they have weakness because of caudate equina compression or something like that, and you immediately have some degree of urgency because of the neurology. And usually you have much more time than you think, and because most neurology happens slowly. If it's happening very rapidly, over minutes to hours, that's probably a vascular etiology to it, and nothing you really do is probably going to change that. So, you get the patient presents with that, and you do your imaging, usually longitudinal imaging and MR and things, and and you identify this, cord compression, and it, has characteristics that suggest it's a tumor. Okay, so is that tumor metastatic or is it primary? So that's where you start into your staging with your blood work and your CT, chest, abdo, pelvis, and da 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 da. And then you usually finish with a biopsy. And the problem is the biopsy is the rate limiting step usually, right? So often you can buy yourself some time with steroids, and that can often be 48 hours where it'll maintain neurology. Now, some tumors, for example, lymphoma or a myeloma, will melt away, with steroids. You have to be a little cognizant of that with biopsies and things. But nevertheless, if you have a strong suspicion it's a primary tumor, what's the strong suspicion? Younger patients, generally posterior element involvement, no evidence of metastatic disease, and then various other characteristics based on imaging. So your suspicion of a primary tumor goes up. And then the biopsy piece, I bring pathologists in on the weekend. It pisses them off, but it's part of the process. And we get the biopsy done, and often you just want to know, is it an adenocarcinoma or is it something suggestive of a sarcoma? Like if they can just make that decision early on, it kind of helps you. So that's kind of the process I take. Most of the time there isn't neurology. But the classic thing at meetings and everything or debates, they say, well, the patient's continuing to get worse. Well, in that setting, you may be able to just do a laminectomy and not violate the tumor, and so create some room for the cord, and then go back, leave it, and then finish your planning, finish your staging, and go ahead and do the definitive treatment. So most of the time, and then you've got to look at, well, if this is an aggressive tumor that can be resected, what do you want to do here in a young patient? Do you sacrifice their life for their neurology? That's a bit dramatic, but those decisions do come up. And then you've got other ones like a Ewing's, for example, where you'll get a great response from the chemo. You may not even have to operate. So lots of scenarios, but I think the most important thing, take your pulse. You don't have to, urgently take it to the operating room without knowing what's going on. You can get most of the staging done and have a really good idea even before the biopsy. So, I hope that helps, but that's sort of the general approach we give to our residents and fellows.
And would there be any precaution for catastrophic bleeding while operating from a tumor if we could know that before entering the operating room or through this framework?
Yeah, I think, when you're dealing with, what are the big vascular tumors, anything with an angio in front of it, and hepatocellular, and probably the most common one is renal cell that we come across. Thyroid will also be that way. Yeah, so you like to know that too. And even when you're in the metastatic realm, you should have an idea of what tumors are vascular and what aren't. And if they are vascular, then, getting pre-op embolization is generally a good thing. There's sometimes your hands force, you don't have time with a renal cell to get it. So then you have everything in your armamentarium to be ready for the bleeding and what might occur. So, and we have lots of good things now to help with intraoperative bleeding. And then of course there's all the medical world with patients coming in on various anticoagulants and things. But in the tumor world, you should have an idea of, which ones are vascular and which aren't.
For sure.
Yeah.
Dr. Fisher, a simple last question that is a little bit personal. Now it is personal. How it is emotionally for you to deal with all of this? Was it hard at the beginning? Now it's getting easier, or it's still, I think, very hard to give this kind of diagnosis to the patients, maybe? How it is for you? How it is for you emotionally? How you deal with it?
That's a great question, and I'll answer it in two ways. I mean, first, it's sort of part of our business. I think if we didn't learn to objectify things and separate our emotions, we wouldn't be able to do our job, not just in oncology and a lot of things. So we all get used to that during medical school and training and things. So that's one thing that I don't think you can do a good job if you can't separate the two. But the second perspective of that is there's a book that really helped, and I actually got this person to give us a couple lectures at oncology meetings worldwide. His name is David Kuhl. It's spelled Kuhl, and he did his PhD in giving life-altering news to patients. And so he interviewed over 1,000 patients. He was actually from Vancouver, and he was a GP and then did his PhD in this. And I mean, his lectures are fascinating, some of the responses that the patients gave him. But he has a couple of things that really helped me provide that information to patients. And some of them are common sense, like don't have your cell phone on, or people don't have pagers anymore, but so yeah, and sit down, like don't be standing at the bedside wanting to get out, right? And often have someone else there, a friend or husband, wife, whatever, partner there. And one thing that was interesting is you ask a patient permission if you're going to sit on their bed, because they consider their hospital bed like their home. And he goes, you wouldn't barge in to someone's home. So I thought that was interesting. And then just the follow-up, because once you give that life-altering news, they're pretty much shut down and aren't hearing much after that. But he just gave a really good perspective of that. It really helped me deal with the whole oncology world. I mean, there's other principles he talked about, but if you get a chance, the book's not that long, but you just get the principles out of it. But it grounds you a bit. Yeah. Perfect.
Thank you very much. That was amazing. I would say it was perfect to bring our discussion to a close. Dr. Fisher, thank you for this insights. On behalf of the Spine Youth Club, I want to thank you for your time and for setting a global gold standard that continues to inspire our generation. It was a true honor, and we look forward to crossing paths with you again soon. Have a wonderful day.
Thanks, you guys. You did it. you guys did a great job. I really enjoyed it. Thanks so much.
Thank you very much. We also
Okay.
have a nice
Yeah,
day.
good luck. Yeah, good luck with your careers. Okay.